Welcome to the Poisoning Prevention in Canada Data, Trends, and Calls to Action webinar. My name is Pamela Fuselli. I'm the President and CEO at Parachute. I'm happy to welcome all of you to the webinar today. Just a couple of housekeeping details before I get started. If you have any questions for our presenters throughout the presentations, we'll deal with those at the end and have an opportunity to have a Q&A session. So if you can use the Q&A button at the bottom of your screen to log any questions that you might have. If you can direct who the question is to as well, that would be very helpful. If you're having any challenges or troubles, you can use the chat button to communicate with the Parachute team who is on the back end of this and taking care of some of the technical running of the webinar. We are recording this, and this is the first webinar in a series of 3. So stay tuned for some additional information coming out soon about the topics and dates and times for the next webinar. I'm going to introduce our first 2 speakers and then hand it over to them to make a few remarks, and then I'll introduce each of the speakers as they are doing their presentations. So our first speaker is Richard Wooten, who I'm happy to welcome to this panel. He is a team leader in Surveillance and Coordination Unit at Health Canada. He's been part of Health Canada since 2009, and in 2013 he established a multi-sectoral task force to define requirements, conduct feasibility assessment, and make recommendations to decision makers on the development of a poison center surveillance system. In Richard's capacity as the team leader and as a collaboration center manager for Toxicovigilance Canada, he is committed to informing action in prevention, treatment, and harm reduction of drug, poison, and chemical exposures. To achieve this, he is passionate about fostering collaboration and information exchange between poison center specialists, public health, regulatory, health security, and non-governmental organizations. It's also my pleasure to welcome Wendy Thompson from the Public Health Agency of Canada to the panel. Wendy is an epidemiologist and the manager of the Injury and Healthy Living Surveillance Team within the Centre for Surveillance and Applied Research. Wendy's injury team manages the Canadian Hospital's Injury Reporting and Prevention Program. You may have heard of it. We call it CHIRP for short, as well as analyses intentional and unintentional injuries and poisonings from a variety of different data sources. So I'm going to hand it over to Richard to make a few remarks, and then Wendy will follow. Richard?
Good afternoon. Thank you so much, Pam, and thank you to the whole Parachute team for coordinating this webinar. Before other speakers talk about the evidence summary, I'd like to thank the team that led the development of this publication. It is just so valuable to bring the community together, to take stock of our current situation, and develop recommendations as to how we can advance collaboratively together. Thinking back to the predecessor document to this one, the 2011 white paper on poison prevention of poisonings in Canada, it was such a valuable document. I think back to the times when we were, sort of approaching decision makers with this idea of developing a Canadian surveillance system for poison information, to be able to reference back to that publication, and also to be able to highlight the call for enhanced collaboration and information sharing that was identified in that publication. So I'm very hopeful. I think that this latest work will be equally as valuable. And I'd like to just take a moment to thank the poison centers for the great work that you do day in and day out to the service of Canadians. To thank the injury prevention centers for the work that you do with the public outreach, the education. as well as to all of the toxicovigilance partners, so the toxicology laboratories, the public health programs, the regulatory programs, medical practitioners, the epidemiologists, the NGOs, and the academics. I look forward to our continued collaboration and on our collective goal of protecting and maintaining the health of Canadians. I would encourage you to keep an eye out for the next webinar that'll be coming out of this series. We are planning a presentation on the collaborative response to COVID-19 related exposures to bleach cleaners and hand sanitizers. And it'll really focus on sort of the importance of timely poison center data and collaboration on early warning of safety signals, collaboration in developing public advisories, and informing action in the sort of the stop sales, the stop distribution of hazardous products, the work on amending and regulations, all of the things that we can do together to sort of prevent those poisonings from occurring. The last item that I'll flag is that the WHO, the World Health Organization, has recently published guidelines for establishing a poison center. And I think it's a very worthwhile read. So I just want the community to be aware of that publication. And I would highlight Chapter 5, which is the chapter on toxicovigilance, which was heavily influenced by Canada and speaks to promoting partnership, enhancing information sharing and collaboration on situational awareness, facilitating early warning of safety signals, conducting targeted health threat monitoring, and enabling reach back to domestic and international subject matter experts. So that's something I just want the community to be aware of. And again, I'll thank the organizers of this webinar, as well as those that worked so hard on putting together this publication. So looking forward to hearing more on sort of the recommendations and next steps. Wendy, I'll turn it over to you.
So I realized I was muted, so apologize. So thanks, Richard. So as Pam mentioned, my name is Wendy Thompson. I am the manager of an injury and healthy living surveillance team. We manage the CHIRP data, as well as we report on a lot of other injuries, poisonings, intentional and unintentional, for a variety of different data sources. And so one of the other groups that we have in the Center for Surveillance and Applied Research is newly created is the Substance Related Harms Division within our agency. And that was a response to the opioid overdose crisis. Since then, they have expanded not only for opioids and polysubstances, including other alcohol, cannabis, vaping, and e-cigarettes. So similar to Health Canada, we work a lot with emergency departments and hospitalizations researchers, but also together with other federal governments, as well as provincial and territorial partners. So we did develop a national surveillance system for reporting on opioid-related deaths. We've also expanded to look at opioid-related overdoses using emergency medical services. And so we have on our data blog, if you Google FAC Infobase, or if you look at any on the opioid crisis, you'll see some of the new releases that we do, and we have moved to quarterly releases, as well as working with CIHI to have the Canadian Institute for Health Information open up their releases for not just closed year, but also open cases. We have special epidemiological studies that we do with coroner and medical examiners data to better understand the risk factors associated with those opioid-related deaths. Public Health Agency and Health Canada has also put in place public health officers. They were placed by FAC directly into the provincial and territorial health departments or the chief coroner and medical examiner's office, and that was determined by the need by the province themselves. So we're doing a lot to understand substance harms, their distribution trajectories. So recently FAC published simulation models on opioid overdose deaths that may occur during COVID-19 outbreak until June 2021. So feel free to look at that. And if you want the links, I'm happy to share that with you. In addition to the work that we're doing on cannabis, e-cigarette, and other vaping products. Again, we're working with Health Canada and US and other countries. And we continue to look at work with Health Canada on also alcohol related. So Canada.ca has a lot of our data sources. All of our injuries and poisonings, intentional and unintentional. So if you haven't heard by now, we're all being asked to refocus all of our efforts to look at the impact of the pandemic, various stages, as well as provincial differences in regional differences related to injuries and poisonings, both intentional and unintentional. So it's very timely work. Happy to be part of it. And thank you very much for allowing me to speak and participate. Thanks, Pam.
Wonderful. Thanks. Thanks to both Richard and to Wendy for sharing those opening remarks with us. It's really important in terms of collaboration and making sure that we are all connected and sharing information like this so that we can be coordinated. That's one of the things that we'll talk about a little bit later. So let me give you a little bit of background on the evidence summary. Give you a little bit of context of where it came from. And Richard referred to this, the original or the first publication about 10 years ago that focused on poisoning in Canada related specifically to children. This was the first meeting that the poison centers from across Canada, the injury prevention centers and injury prevention experts, along with the federal government, so that was both Health Canada and the Public Health Agency, came together to talk about this issue and to understand and learn from each other. And the product was that first white paper that was released. So a couple of years ago, Dr. Kathy Belton and I, who led and coordinated that effort, took a look at the document and realized that there had been some significant improvements, and it was probably a good time to take a look at what was going on currently in poisonings in Canada, and to expand the focus to all ages. And so what resulted with another huge collaboration between poison centers, poison experts, toxicologists, injury prevention experts, both Health Canada and Public Health Agency, again came together to look at what is the current data, what are some best practices, what has changed from the previous year, and what recommendations would we go forward with at this point. So that's a bit of a context as to how the evidence summary came to be. So it's my pleasure now to introduce our next panelist, Dr. Kathy Belton, my co-author. She is the Associate Director of the Injury Prevention Center in the School of Public Health at the University of Alberta. The Injury Prevention Center's mission is to reduce the societal and economic burden of catastrophic injuries in Alberta by building partnerships, promoting effective strategies, and sharing knowledge. In addition, the center participates in injury prevention research and initiatives across Canada and internationally. Dr. Belton's research focuses on knowledge translation for the prevention of unintentional injury. Kathy's area of interests are concussion, motor vehicle, and farm-related injuries and fall prevention for seniors. Kathy has a Master's of Education, specializing in adult education, and a PhD in epidemiology at the University of Alberta. In 2013, she was awarded the National Leadership Award for her work in injury prevention. As an injury survivor, she knows firsthand the impact of preventable injuries. Welcome, Kathy. I'm just going to load your slides up here.
Thank you. And thanks for that introduction, Pam. And before I start, given the methodology and the findings from our study, I'd just like to thank all those people that were involved in this, in the evolution of this report and in the final product. I really appreciate all of the help. Next slide, please, Pam. Next one. So I'm going to jump right into our data sources. We use data from death data from Stats Canada, the vital statistics database. We used hospitalization, and we got that from CIHI's discharge abstract database. And again, all the data that I present today will not include Quebec because they don't report to that database. And emergency department data, we got that again from CIHI, and it's called NACRS data, the National Ambulatory Care Reporting System. And emergency room data, we got that from CHIRP, which amalgamates emergency room data from 11 pediatric and 9 general hospitals in Canada. And then we used case records from the Canada's Poison Prevention Centers. Next slide. So the data are presented with rates of 100,000 and standardized to the 2011 Canadian population, and age standardized rates are used throughout this report to describe rates across time. There are several limitations to the data. Statistics for mortality due to poisonings are based on the underlying cause of death, which is an important point as poisonings can often play a pivotal role in deaths, but may not be coded as the underlying cause of death. The statistics presented can only be seen as a conservative estimate of the true burden of injuries in Canada. So, for example, a death due to a motor vehicle collision under the influence of drugs or alcohol would most likely be coded as a traffic-related death, with poisoning being a supplemental factor. The second point is that data do not capture the growing burden of substance-related addictions and mental health conditions that often involve substances such as opioids and illicit drugs. Data on deaths, hospitalizations, and lost my page here. Data on deaths, hospitalizations, and emergency department visits due to mental health addictions and substance use related conditions are beyond the scope of this report and are actually captured with other ICD-10 codes not used in the evidence summary. Next slide, Pam. The other limitations is that the majority of cases are self-reported by individuals. So with the possibility of errors on the part of the caller and the limitation that exposures to substances are not always confirmed. And data presented may not entirely be reflective of the entire country. A majority of calls received by particular poison centers is from a province that it's situated in, since several jurisdictions in Canada do not have a local poison center and instead rely on services of nearby poison centers in another province. Margaret Thompson, who you'll hear from later, will be speaking more about the poison center data in the next presentation. Next slide, the findings. So this is what we really want to get to. So approximately 4,000 Canadians die each year due to poisoning, and unintentional poisoning deaths have now surpassed traffic-related deaths in Canada. And deaths from unintentional poisonings are on the rise, as shown by the graph in the next slide. So, as mentioned, poisonings have now surpassed traffic-related deaths in Canada. And you can see here that in 2017, there were twice as many people died due to unintentional poisonings compared to transportation-related injuries. So we look at the next slide, please. This is the mortality due to poisoning by intent. And we'll see that unintentional poisonings are on the rise from 2008 to 2018. And the death rate increased by 11.4% each year. And the rates for males are consistently higher than both females and for both unintentional and intentional poisonings. Next slide. Sorry, I'm having trouble with my slides here. Hospitalization rates for unintentional self-harm poisonings were consistently higher than unintentional poisonings, as this graph shows. When analyzing data between females and males, rates for unintentional poisoning hospitalizations remain quite similar from 2008 to 2014. However, rates among males in the later end of this observation period increased compared to females. Moving on to the emergency room data. Again, this is just Alberta and Ontario. It demonstrates that there's a gradual increase in visits due to both unintentional and intentional poisonings, with the rate of unintentional poisonings being more than double that of intentional self-harm poisonings. Males comprise a greater proportion of emergency department visits due to unintentional poisonings, whereas rates of intentional self-harm poisoning were higher among females. Children under 5 years of old had the highest rate of emergency department visits for unintentional poisonings during the observed period. Next slide. So when we get to looking at the opioid crisis, hospitalizations due to opioids increased by 27% between 2013 to 2017, with an estimated 17 opioid poisoning hospitalizations each day in Canada. Opioids such as fentanyl and heroin have become a major cause of morbidity and mortality across Canada, to the point of a national crisis. Much of the outcomes are due to unintentional opioid poisonings rather than intentional self-harm or suicide. And males are the major population at risk for these related poisonings. Nearly half of all related poisoning deaths in Canada were among those aged 30 to 49, and 3/4 of these were males. So that's just a brief sum of what data that's in there. But we know that there are certain populations that have been identified through research and surveillance as being at an elevated risk for poisoning. And these populations are pediatrics, those usually, especially the 0 to 5-year-old age group. And this is mainly due to developmental or environmental factors. Youth and young adults, and these factors, the factors that lead them to be more at risk are impulsivity, rebelliousness, risky behaviors, and peer pressure. And this we saw a lot of when we saw the Tide Pod Challenge. Older adults are more at risk because of polypharmacy and adverse drug effects. And Indigenous peoples, they're more at risk because of complex issues such as intergenerational trauma and reduced access and barriers to health services such as addiction and mental health services. So that's just a brief look at some of the data that's found in the evidence summary. I would encourage everyone to flip through that chapter of the evidence summary and to email any questions you have to Pam or myself. So thank you, and I'll turn it back to Pam.
All right. Thank you, Kathy. I am going to now introduce you to our next panelist, Dr. Margaret Thompson, who is the medical director at the Ontario Poison Centre, as well as the president of the Canadian Association of Poison Control Centres. So Margaret, as I said, is the medical director of both the, I guess not both, but Ontario, Manitoba, and Nunavut Poison Centres, and is a practicing emergency physician at St. Michael's Hospital in Toronto. She's also been the program director for the Clinical Pharmacology and Toxicology Royal College subspecialty program at the University of Toronto. She is most proud of her current and graduated fellows, all of whom are now leaders in both clinical pharmacology and/or toxicology in Canada. She has presented a number of toxicology topics at continuing education venues and has been nominated for and won a number of teaching awards. She actively works with the coroner's office, Public Health and Health Canada on toxicology surveillance, chemical emergency preparedness, and evidence-based care of the poisoned patient. So welcome, Margaret, and I will turn things over to you.
Thanks, Pam. I'll just see whether I can organize myself here to share my screen. Just give me a second here. And presenter mode. Okay, does that look good to you, Pam?
Yes, it looks great. Thanks, Margaret.
Okay. So thank you for that introduction, and thank you to Parachute for allowing me to speak on behalf of Poison Centers and to share with you basically how Poison Centers work, some of the data that we do collect, and to give some examples where Poison Center data has informed public and government policy to improve the health of Canadians. I have nothing to declare except that by some circuitous route, I am paid by the Ministry of Health and Long-Term Care to provide medical direction to the Ontario Poison Centre 3 days a week. So introduction to Poison Centers. There are 5 across the country serving the majority of Canadians. The 2 provinces that do not have official poison centers make available to their public an 811 or telehealth sort of service so that the general public can call about exposures in those provinces. I must tell you that any of the information that I give you about Poison Centers and any data that I might share with you in this presentation does not include any of the telehealth calls, as we're not affiliated with them except in a very general way. So although we are spread across the country and may be sponsored by different institutions, in some provinces we're sponsored by government, and others, for example, in BC by BC CDC, and other places in various hospitals. We all operate in approximately the same way. I show you a picture here of one of our specialists in poison information. We call this person a spy, and she and her colleagues across Canada all are so have significant orientation and training in care of the poison patient. After 2,000 human exposure calls and 2 years working in a poison center, each specialist is eligible to write their examinations in toxicology, and then if passing those examinations are certified. To be an accredited poison center, each poison center must have at least 50% of their staff are certified in poison information, and so are C spies, and these may be regulated RNs or pharmacists in the jurisdiction in which they are practicing. Every poison center must have toxicologists as backup so that when the care of the poison patient is beyond the scope of practice of the RN or the pharmacist who is answering the initial call, there is a toxicologist who's on call and available to kind of jump in and support the specialist, speak directly with the consulting service or physician or pharmacist or whatever across the country. There are other requirements for accredited poison centers, but they're not relevant right now. I wanted to thank Kathy and Pam for the introduction to the evidence survey on the prevention of poisonings in Canada, and bring just some of the highlights, and I will not touch on any of the things that Kathy said, but the burden of poisonings is well documented in that evidence summary. It includes deaths and hospitalizations for intentional and unintentional exposures, dollars and life years lost as a consequence of exposures happening to Canadians every year across Canada. I will just, emphasize some of the information about poison centers, and from that document, there it's noted that there was approximately 209,000 exposure calls to the 5 Canadian poison centers. So that represents about 575 calls per day. I might mention here that reports of poisonings are not obligated anywhere in Canada, meaning that if you think that someone in your household has been poisoned and you're a member of the public, you are under no obligation to call a poison center or a public health unit to report that occurrence happened. There's a number of reasons for this, and some of them are related to, not having available the health card at the time that you think that you may need to make the call, and that's not required by any of the poison centers, but the public may not know this. The public may not know that we provide language support in 164 different languages through a language line. And so if your first language is not English or French, you may not think of calling a poison center. You may not understand that a mouthful of bleach might be an exposure and might cause harm to the person that you might be calling about. And again, from the healthcare provider's point of view, if I'm acting as an emergency physician in an emergency department and I see a patient in front of me who has taken an aspirin overdose, for example, and I feel comfortable managing that poisoning, there's no obligation for me to call the poison center and ask for more help as to how to manage that case, or to report that case to anyone so that we have better statistics. So the numbers of calls that come to poison centers is probably the tip of the iceberg. That being said, if we take the scenario where 80% of the calls that we get are from home, and we keep 80% of these callers at home following an exposure with some self-care. To irrigate a site, for example, if you've got an exposure in your eye or on your skin, if we tell you to irrigate it and use soap and water to clean it off, if we tell you that that's not a dangerous exposure, although it is an exposure, and we give you some poison prevention advice at the end of the call, when we've established that it's not worrisome, then that's potentially over 134,000 calls a year where there's been no contact with a healthcare provider other than the poison center. So we have information about a number of potentially worrisome exposures that don't turn out to become worrisome, but that could have been prevented because we understand the scenario by which these poisonings occurred. These numbers are not included in any of the databases that Kathy mentioned that they had used when we came up with the evidence summary. So CHIRP does not become aware of these exposures because these patients never end up in emergency departments. NACR's data does not include these because they're not in emergency departments. They're not so severe as that they need hospitalization, and so they don't end up in CHI data either. So this is a large number of exposures from which we can glean information that might make the health of Canadians safer. And as noted in the evidence summary, for every dollar spent on the operations of poison centers, $7 is saved to our healthcare system. When we get a call, so when I say we, I'm speaking about the specialists in poison information at all the poison centers across Canada. We enter information into a call management software that in BC, Ontario, and IWK or Nova Scotia, we call VDL because of the name that our vendor has given to it, but it leaves space for all sorts of drop-down menus to document every exposure call as if it was a chart from a patient who presented to an emergency department, for example. We have caller information, we have patient information, we get phone numbers right away so that in case of the technology fails, we can call back the patient to find out what's been going on. We document in many different categories as to the intention of the call, what happens to the patient, a verbatim history and recommendations, as well as many drop-down menus in this child chart that's at the bottom of the VDL chart. Indicates what treatments have been done and what we've recommended as well, what symptoms the patient might have, the route by which they were exposed to something, laboratory results, that when we have those available to us. Just an example of a drop-down menu at one on our chart. This is for an exposure call, and we classify the exposures being as unintentional. Those are mostly the childhood exposures, and the intentional ones, and we have to make judgments as to whether it's a suspected suicide or whether it was an intentional, but meant to abuse a drug and not meant to get in trouble with the drug, for example. But at this point, I might point out that there are many limitations to the data that we might then be collecting, because our mandate, our first mandate, is to provide care to the acutely poisoned patient. And so in the interests of time, when a specialist gets a call from a caller, it's important to establish that the patient who has been exposed to something is not in extremis, and that we don't direct them to call 911 because they need better attention than we can offer over the phone. We also, in the interest of time, might make a mistake when we're clicking on one of these particular options, and we might click intentional misuse instead of abuse if we've made a judgment call as to how that particular exposure might have occurred or why it might have occurred. Some of our information might be missing because a patient may hang up after getting essential information, and we don't fill out all of the categories. And finally, we do not verify that the call is about the substance that the caller has stated they used. And for an example, it might be that a caller thought they took too much aspirin, and in fact, it was acetaminophen. We don't verify by doing laboratory testing for every call that we get. To determine whether or not it's true that all the signs and symptoms that that patient complained of, etc., were because of the alleged exposure, as compared to what is in the end turned out to be the exposure. We try to follow all calls to known outcome, but there are many that may be lost to follow up because the patient might tell us they're going to a hospital from which they did not go. They say they're going to go to their nearest hospital, and they end up going to one that's further away because the wait in the emergency department is too long. So there are a number of reasons why we may not have full information, but based on what we have, we can come up with a number of different information categories, and we can do follow up on a lot of different patients. And come up with trends. And I've taken this from the evidence summary. So over time, we know that most of the calls to poison centers across Canada have remained stable. And the gray line here is that from the Ontario Poison Center. So that the calls in our jurisdictions have been increasing. And some of that would be because we have included Manitoba and recently added Nunavut to our call jurisdiction. And so some of it is just an increase in the population by which we serve. We also might be giving, have information about whether the majority of calls that come to poison centers are unintentional, as in the blue area here, or suspected suicide, and we can follow those trends over time. We have information about those patient populations that are most at risk because of documented calls to poison centers. The 5 and under age group, represented in orange, as Kathy mentioned, is a very high risk population because of a number of factors. We have data on what kind of effects may have occurred because of exposure. A minor effect might be that the patient vomited once, and a major effect might be that they have repeated seizures or they had a cardiac arrest, for example. And we keep trend data as to the most common substances that people may be in particular age groups may be exposed to, and that helps us with our poison prevention messaging. You know, if it's analgesics that young children are most likely to be exposed to, then we can target this patient population by talking to mothers groups, et cetera, about keeping your medication, the analgesics, locked up and out of sight. Targeting when you're buying at a pharmacy an analgesic, for example, ibuprofen or acetaminophen, the pharmacist can give that kind of information, that these are the most common exposures that that age group would have. And please remember that these are medications as well, even though they're over the counter. I wanted to bring up three areas where poison prevention, data has informed policy and manufacturers as to what might be better, safer for Canadians in general. So in 2012, laundry detergent pods were introduced into the marketplace. And it became observed by poison centers that we got increasing calls regarding children and detergent exposures. And in fact, it was these pod exposures that the increase in the detergent exposures were representative of. These pods are colorful and appear like candy to young children, and children would often bite into these particular pods, into any pod, and this liquid that was in these pods would explode in the eyes of the children, and there's a number of ophthalmological injuries that occurred because of that, or explode into the back of the throat of children, and as a result of that cause airway compromise and swelling, such that children had to be admitted to intensive care units. They had to have tubes put down into their lungs to open up their airways, and they had to have medications given to them to decrease the swelling so that the tube could be removed eventually. Also, in the contents of these particular pods, it became known that some of these pods contain substances that would cause a child to go into coma. So because of the information gathered by poison centers, documented in the literature, governments, including the Canadian government, came up with regulations as to the packaging of these products. And some of the manufacturers, including Procter & Gamble, came up with poison prevention campaigns that included this one, which suggests, number one, in this infographic, that these pods should be up and out of reach of children, that they should be locked, and this would potentially keep your child safe. In fact, some of the regulations included that these containers had to have latches on them when initially they did not, and they had to be in opaque containers so that the children could not see the colorful contents inside. Just yesterday, this particular letter was published in the Canadian Journal of Emergency Medicine, where ophthalmologists commented on increase in exposures to these particular products for children, despite these poison prevention campaigns that have been launched and the regulations that have been launched. These injuries are still occurring. Changing, I guess, tracks, I might mention again about another area where poison prevention or poison data has made a difference to public policy, and that would be in exposures to marijuana in pediatrics especially. And this literature is from the Denver Poison Center and the Colorado the Colorado Health Systems, before and after marijuana was legalized in Colorado. So that was it was legalized in 2014, and almost immediately poison center calls were increased by 300%. This kind of information informed Health Canada then with the Cannabis Act, and certain regulations were imposed on the Canadian products that would be brought to market and were legal, such that all products must have the standard cannabis symbol on them, that any product could not contain more than 10 milligrams of THC that in a single package, that all packages had to be child resistant, that all chat packages had to use standard colors, such that you could use, they could be non-attractive to children, and they could use brown, beige, and grays in the marketing of your cannabis edibles. Despite this, this was released yesterday in British Columbia. The Go Public investigation found, lots of products that were very attractive to children, that are, duplicates almost of commercial candy that is available out there. And stoner patch dummies, certainly are very similarly packaged, but illegally, to Sour Patch candies that are available to children. It's very difficult to regulate things that are brought into the country via the internet, but it was through poison centers that we identified that these sorts of products were all across Canada, and we've liaised with Richard Wooten's group at Health Canada, such that the RCMP is now involved in trying to get these products removed from the marketplace. Finally, I'll just mention briefly, because Richard says our next seminar is about the COVID cleaning products. At the beginning of COVID, all of the products that we would use to clean our homes were in very short supply, and manufacturers were making alternative hand sanitizers and packaging them in illegal packages because of a lack of containers, I would presume, for these 70% alcohol containers. And this product was found by caller to the Ontario Poison Centre in one of our usual marketplaces. This is a 2-liter bottle, which looks like a container that you should have some kind of pop in. We found other similar containers that looked like alcohol bottles, wine bottles, etc., that contain 70% alcohol, marketed as hand sanitizer. It was because of knowledge of these sorts of calls, in interactions with consumer products in Health Canada and other branches of Health Canada, that we've been able to have these sorts of containers removed from the market and decrease the risk to Canadians at thinking this might be something that was edible or palatable so that they might be drinking it. So finally, I'd like to thank Parachute for the opportunity to present on behalf of Poison Centers and welcome any of your questions at the end of the seminar in total. Thanks very much.
Thank you, Margaret, for that presentation. Very, very informative, and I think the examples that you use, those real world examples, are familiar, unfortunately, to many of us, and if not, will be as we go forward, unfortunately. Finding those products that look so familiar as candy products or as wine bottles or beer bottles. In those cases, the intention was good, but the execution was maybe some problematic. So I'm going to wrap up the presentations this afternoon with some thoughts about implications for prevention. So talk about what the evidence summary is looking at in terms of best practices. What do we know works or has promising practices? And when we talk about best practices, we want to spread the net wide, but make sure that it's still based in evidence, but also with feedback from stakeholders with real world experience. But the ultimate goal of best practices really is to get the most effective interventions activated on, with scarce resources. No one wants to waste time on things that don't actually work. So we talked a lot, and thank you, Margaret, learned a bit about poison centers. Recently, we did a survey with parents about related to cannabis poisoning with children. And what we found, unfortunately, was that only about 40% of Canadian parents know their local poison contact information. We often pair our messaging around poison prevention, like keep it up high and locked, with the with the recommendation to make sure that your local poison center number is kept near a phone, logged into your cell phone, etc. And so it was interesting to know that while was and is such an important way to access care in an emergency, only 40% of parents know that contact information. So public health policy is quite important, and we can see, as Margaret talked about, the policy changes with the laundry packets. This policy regulates access as well as their safe manufacturing and packaging. And we heard a lot about that in Margaret's talk as well. These are a couple of legislation that is at the federal level, but certainly there are some at different levels of government that can have an impact on reducing poisoning. The Canadian Consumer Product Safety Act and associated regulations, I remember back when that was introduced and finally passed, it replaced a 60-year-old Hazardous Products Act that had been revised over time, but certainly needed a major overhaul to account for some of the major changes like internet shopping and access globally to products that didn't used to be able to be accessed by Canadian consumers. This policy needs to be informed by the best available evidence. So those epidemiological data and the trends, as well as lived experience, this experience with, the Tide Pod Challenge, what kind of qualitative evidence do we need that would make a big impact and affect access and prevention of poisoning. Safe packaging and storage is crucial to help prevent or delay access to medications and substances. Sometimes you hear this being spoken about as child-proof packaging. And there have been some challenges with this in terms of making access to medications difficult for children, but easy enough for adults that might need to access the medication themselves. So, for example, arthritis medication, having a packaging that will not allow quick access by children, but do allow the adults to get into it. And so when we talk about child-resistant packaging, what that means is that at least 80% of children that are being tested can be prevented from opening the container during a 10-minute test. So it delays access. It doesn't prevent access. So that's the difference between child-proof and child-resistant language. And so, there still is access. This is still a reason why keeping medications and other poisons up high and lock is required. So when child-resistant packaging was introduced, it was shown to be really effective, and it is required by law for certain medications, as I said, and as I said, not child-proof, just child-resistant. Margaret touched a little bit on this with the laundry packets and the visual attraction of products that are not meant for children. So avoiding colorful and enticing package designs, those bright, colorful colors of Gatorade bottles and the laundry packets, etc., and that they aren't in packaging that is clearly, or in containers that are clearly seen by children who would want to then want to get into the product itself. Unit dosing. So this is those blister packages that you see, which requires you, if you wanted to take or access a large number of the pills that or capsules, that you would have to break open each individual one. Again, this is a delay tactic and limits the quantity of potentially harmful medications. This one there is still some lack of evidence around the effectiveness of this approach, but it certainly has had some positive outcomes in research. Keeping the substances in their original packaging is important, both for that access aspect, but also if you need to call the poison center or you do end up in an emergency department, that you're actually able to tell the healthcare provider, the spy, as Margaret called them, the emergency room physician or nurse, what your child potentially has taken. And so there was last year a number of campaigns that were done, particularly with cannabis in mind, looking at how do you store medication and cannabis as a drug safely. Parachute used a little humor and tongue-in-cheek by having a large green gummy bear with the THC logo on it, represented on various high Canadian landmarks and locked up, really to get that message home that it needed to be high and locked. And the second one is an example of what the Injury Prevention Center and the Alberta Poison Center did as well to get this message across that substances need to be stored high and locked. The same survey that I referenced at the beginning showed us that, well, 90% of those that polled, which were largely parents, agreed that it was important to do this, to keep your medications high and locked. Only about 30% actually reported doing so. And we know self-report is not the most reliable way. So this certainly leaves some room for interpretation. But for those that were willing to admit that they didn't actually store their medications and poisonous substances high, this is quite concerning. There are multiple component approaches to substance use. And so drug and substance use can take a number of forms: that harm reduction measures, access to treatment and services that may help to prevent death from unintentional poisoning. And Canada, along with other countries, have adopted these 4 pillars: harm reduction, prevention, treatment, and enforcement to approach this issue. So what are some of the recommended actions that the evidence summary had? We need some sustainable solutions, and we've touched a little bit on the opioid crisis. Right now, short-term initiatives to address the issue around deaths and is basically a response to the immediate threat has been taken, but we really do need to develop sustainable solutions to the opioid crisis. And when we look at the numbers of increasing poisoning, opioid, what is called overdose, but really is a poisoning, is concerning us. Kathy and Margaret and Richard and Wendy talked about the different surveillance systems that we have in Canada. The integration is what we really want to focus on. So across all that data collection structures, so that we get a full picture. As Margaret outlined, you can see if we only focused on the hospitalizations, deaths, and emergency room visits, we would miss a large proportion of poisonings in Canada. And so the development over the last number of years of the Canadian surveillance system for poison information is a huge step forward and is expected to be coming online very shortly. Access across the country in an equitable way is also something that really is needed. So providing a 1-800, a toll-free number to connect people from wherever they are to whatever the closest poison center is to them. So even if they were traveling across the country, they wouldn't need to know the local poison center number, which is what they would need to now. So we create this seamless access. This currently exists in the United States. And so really looking forward to the time when Canada has something similar. The other recommendation is around products themselves. So implementing a products database that gives product level information to inform that medical treatment, whether it's in an emergency department or a call to the poison center when exposures occur. We don't currently have a national products database. And what does this, why is this a challenge? Well, it limits access to this information that can inform. So similar to keeping the medication and products in their original packaging, it gives a lot of information to those who are trying to care for someone who has and is experiencing a poisoning incident, that they know how to respond to it. But it also contributes to missing signals and doesn't allow comparison. So you may get something high level that says, energy drinks, but it doesn't drill down to particular brands, sizes, or the frame of time when that product was made. And so this does present quite a few challenges for those who are trying to address a poisoning when it occurs. And lastly, national leadership and coordination. So having that national level organization, and we have a collective that is working and functioning in leadership areas, moving this agenda forward. So having someone who is leading the charge, as it were, and we are currently all doing that together. But if there was a national organization that we knew we could turn to, and there are a couple of candidates that are there, that may be something that we want to look at. And we are developing this collaborative among the different stakeholders. So what are the prevention strategies? What are some of the issues that are rising, like the gummy or the recent candy and cannabis piece? So what do we need to do to work together for Canada? And we have begun this. There is a public outreach and communications working group, as well as some other working groups focused on other issues that is part of Toxicovigilance Canada, that brings together on a regular basis poison centers, injury prevention centers across the country, and the federal government, so Health Canada Public Health Agency, to have conversations about what are the trends, what are some of the proactive steps that we can take, what's the information that the public needs to know. And so for the most part right now, we are working on collaboration around Poison Prevention Week. And I just thought I'd take this opportunity to let you know, this year it's the 21st to 27th of March. And the overall theme is really to try to put empower the Canadian public around action that can be done. So prevention, it's in your hands. You can do something about it, specifically around things like hand sanitizers, household cleaners, cannabis, and illegal substances. This allows the poison centers and those of us in injury prevention working across the country to take a look at what is happening in our own backyards and focus and embed that information into a broader national campaign. So that's the end of the formal presentations. I'm going to hand it over to Stephanie Cowell to bring forward any questions that have been asked by the participants. So if you haven't asked your question, please do so now. We'd be happy to answer any of those questions. And if you can direct it at a particular person, that would be even better. And I will hand it over to you, Steph.
Thanks, Pam. And thank you, of course, to all of our presenters. What fantastic quality information. I will invite all of our panelists, if you are so brave, to turn your cameras back on so that we can answer the questions from the audience. I'd first like to acknowledge one question that was about where the information is located on the World Health Organization website about the guidelines for poison centers that Richard mentioned. We are going to share a link to this information immediately following the webinar. So we will share that with you and point you to the information that Richard highlighted. As well, I will also plug that in that email, we will have an evaluation survey. And in the name of tracking and quality improvement and reporting, we would love to have your feedback on this webinar so that we can continue to know that these professional learning opportunities are useful and formatted in a way that support the field. Okay, that's my spiel. Moving into a question from Kara, who joins us from Saskatchewan. Kara's question is, if a person calls a poison center, then goes to emergency, but a death occurs, does the poison center and the emergency department communicate that for the statistics? And if Kara doesn't mind, I'd actually like to divide this up into two questions, break it down a bit. How poison-related get reported? How do they end? And the second question, which Pam alluded to a little bit in the implications and recommended actions piece, is there integration or communication between the different systems of data? So in particular, the poison center and the health system. So I'll break it down that way, and I'll open it up to anyone who's willing to speak to how this data gets reported.
Stephanie, I didn't hear your first question. The internet seemed to have broken down.
Oh, I apologize. Can you hear me clearly at this time?
Yes.
Okay, great. So the question was, if a person calls a poison center and then is sent to emergency, but it results in a fatality, does the poison center and that emergency department communicate their information for the statistics? So how does a poison-related death kind of get reported and into the data systems that we're looking at?
I can take a stab at that first part of the question. It's not particularly well integrated. So if a person calls the poison center, we recommend that they go to an emergency department. We will follow that patient from a poison center point of view to known outcome. So if we become aware which hospital that patient went to, we will call the hospital and tell them to anticipate this patient's coming, or we will give advice if they were to call the poison center as well. When the patient arrives and say, we've got this patient, they've said they called you first. What did you recommend? What should we do? We will then follow that patient to known outcome. And if it turns out that the patient dies in the emergency department, that information will be reported higher up through NACRS. At the poison center level, there may have been continued communication between the healthcare teams based on, we're giving advice about something. And we may have some local education around that sort of a situation, that there may be rounds of morbidity and mortality. We invite the emergency department staff to come to ours, they invite us to theirs. But there's no formal reporting of anything that we know as being ended up in a death to any other body. So from my point of view as a medical director, I keep track of all the patients that I know died from a poisoning, and I will do regular morbidity and mortality rounds and education of our own staff about, potential care changes for that particular kind of a poisoning, but there's no reporting up a higher chain. Except with Toxicovigilance Canada, when the surveillance system becomes in effect and we're not just doing, test data, there will be information available on the surveillance system as to how many deaths and what from across the country.
And maybe I'll just jump in there quickly and encourage Wendy to jump in if there's anything she'd like to add to what I'm about to say. At that point in time where you could access that fatality data from what's been collected by the Canadian Poison Centers, there would still be no way of knowing if there is a multiple count. So for example, the emergency room, each CHIRP may be reporting that exact same fatality case. So you can't just take the numbers and bring them together, because there's definitely going to be some overlap. Wendy, would you want to add to that anything further? Okay.
Pam, did you want to add?
No, I was just going to say if Wendy might be on mute, but yeah, if she wants to jump in. If not, we can go on to the next question.
Okay, we will move forward, and if Wendy pops up, we will give her the floor. A question for Margaret. If a poison center gets a caller that needs 911, can the poison center connect the caller directly to 911? Or what does that process look like?
At this time, we do not have any backdoor numbers for 911 services. And in the province of Ontario, dialing 911 means from your cell phone will connect you to the closest 911 service. So we are not able to connect someone directly to a 911 service. We have to tell the caller, this is a very worrisome exposure. Please hang up now and dial 911. We tend to follow those to be sure that that did occur and try to find out which hospital that they may have been taken to, but that's not always a seamless process.
Great, thank you. We have another question from Ian out in BC. Given the 100,000 and more per year, the cases that are dealt with by the poison centers in Canada, but don't end up going into the health system, is this success communicated publicly by the media, the social media? He says it seems to him that communicating the success of poison centers would be a good way to promote their presence to the public. Any comments on that?
The resources that are given to poison centers are mostly for our mandate to manage care of the patient. And so we've had limited ability to do these public outreach campaigns, for example. And it's only through groups like Parachute, who we've been working with Pam Fuselli for years, that some of these successes are published in things like the information publication that came out in July of 2020, and through working with our partners at Health Canada, Richard Wooten's group, that these things have the successes of poison centers have come to the forefront. So in the last 5 years or so, and prior to that, with information from Parachute, been the only way we've had to publish these successes.
And if I may speak up here, I would say that I think this group together and through Toxicovigilance Canada and the surveillance platform, that we are looking to up the profile of poison centers and the importance of this data, which Margaret, you did such a fantastic job of communicating today. I think we have some things in store to try and create a higher profile and more public and decision maker and policymaker knowledge of the poison centers and the valuable role that they play. We have another question about poison centers, of course. How well used are the poison centers by healthcare providers in acute care? So it was shared that only 40% of families and caregivers know the poison control center number. Is there also a need to educate acute care providers to use poison control centers as a resource?
to be able to answer that question, and I'll take this question again, there are many ways in which we educate healthcare providers. And one of those is, the presence that all of us as poison directors have in a number of different universities. And so all of us as qualified toxicologists across the country would teach at the undergraduate medical school level, as well as the postgraduate residency level, taking physicians in training to do electives in toxicology so that they learn more about what poison centers will do. And then kind of by inclusion, if you are the staff person working in a hospital emergency department or ICU, you would encourage your residents and such to call poison centers and give them information about what the value of poison centers is. In various poison centers have different uptakes by healthcare providers. The Ontario Poison Center actually has at least a third of their calls come from healthcare providers, where that's a much smaller percentage in some of the other poison centers. And so maybe the success in Ontario has been a little bit bigger, wider, so that we're getting more healthcare providers calling us. It helps with certainly getting information about the exposures that are out there. And, the epidemiology of poisoning across the country.
Excellent. I have a question. Maybe I will direct this towards Pam and Kathy, as those working really in organizations that do a lot of work out in the community and engaging communities across the country. We have one participant asking, aside from what they normally do kind of in their local area, maybe to support things like Poison Prevention Week, or getting good messaging out, is there anything else communities can do? She states that they are trying to start an action group to focus more of their strategies. So any thoughts on the community activation side?
I think one of the main ways to activate any community is to really focus on the community stories. So how has the Poison Center, for example, affected a particular community? Has there been a poisoning event in a community that you can get that parent to talk about? And talk about the fact that the Poison Center was there and it directed them to care, and hopefully there was a happy ending. We like the happy ending stories, and so do the media. So the media would really glom onto that and promote the success of the Poison Prevention Center, and it also might spark some more action from the community. Pam, do you have any other thoughts?
Yeah, I would agree with you. And yeah, having a storytelling, the data for those of us who really like data, and obviously it's essential to have that data, but we need to turn it into something that really sticks in the minds of the people that we want to, get that information and be able to take action in their own lives. So storytelling is a really good way to do that. There are some, I think, concrete actions around that would relate to any age group. So things like medication roundups, making sure that the message gets out to the community that they should be returning old medications to pharmacies to get rid of it. Don't flush it, getting some of those. So getting the actual substances out of the home to begin with. So I think there's a couple of things that can be done at the local level, and understanding you would have the best idea of what your community is, the demographics is made up of parents and, older folks and youth and Indigenous and all the different ages that are at risk. And go where they are. I think that's the other tip, is to understand where they would normally go, where they would get their information from. So a parent or, a senior over 65 is not going to go on, TikTok or Instagram, but the youth group is. And that's really how we think about reaching out to those audiences. Where are they already going? There was a comment around mommy bloggers. Yes, absolutely. We've engaged those at different times in different campaigns. So who are the influencers? Who are the champions? Is there someone in your community that's had a personal experience, as Kathy said, that could tell the story and really make it resonate, so that the group that, might be influenced by that person really kind of thinks, oh, wow, that either could happen to me or almost happened to me, or I never want it to happen to me. And how do I prevent it?
Absolutely. Certainly something I'm gleaning from this discussion, and I think that came out in the evidence summary as well, is there's some things we really need to address at a system and policy level, but there's also lots of action to be taken at the individual level, whether it's in our professional or personal lives. I think there's lots that we can all contribute to combating this issue. I have a couple more questions for Margaret, again, digging into what the poison centers do. This is a multi-part question, so I'll do one at a time. So first of all, how does the poison center obtain lab results? And do you issue lab requisitions to the patient if needed?
So we don't take individual care of patients. So when we're covering, in each of our poison centers covers multiple provinces and in thousands of miles of care, we would encourage a patient who we thought has an exposure to either go to an emergency department if the exposure was something that was acute and worrisome. And we would liaise with that emergency department to get the results of tests. So therefore, we can then help with, providing care. And if it was something that was not as acute or not as extreme, we would have them go to their family doctor and have the family doctor call us so that we could give suggestions as to what laboratory testing was necessary.
Okay, great. I think that takes care of the rest of the question, which was about lab results collected at the poison center. But as we see, that's not how the process works. So thanks, Margaret.
Okay, thanks.
Richard, I think you've been a little too quiet for a bit. So a question for you. What is the process once Health Canada receives information on an illegal product or something gets reported to Health Canada? I'm sure it's a bit of a complicated process, but in a nutshell, what happens?
Yes, so there are various mechanisms for these incident reports to come in. And sort of each of the regulatory programs do have incident reporting, sort of websites, generic email accounts. What I can really speak to is sort of the collaboration that we have with the Canadian Poison Centers and sort of partners on Toxicovigilance Canada. So essentially, what we are in the process of doing is formalizing our process for these reports to be coordinated through our team and delivered to the appropriate partners within Health Canada. And essentially how it currently works is the poison centers typically will send an email, they'll make a phone call, and it'll come to me and it'll be, okay, is this a natural health product? Is this a cosmetic? What exactly is it? And our team will actually coordinate the delivery of that information to the appropriate regulatory program. So basically, sometimes it's a bit of a shotgun approach where I'm going out across a multitude of Health Canada programs to say, okay, who owns this and who should appropriately take the lead. So maybe what I'll do is I'll give an example. We were contacted by a poison center with regards to a snack pouch. And the snack pouch had cartoon characters on it, and it actually contained hand sanitizer. So essentially what we did with that is we reached out to the regulatory operations and enforcement branch, compliance and enforcement, coordinated the delivery of the information from the poison center to the regulatory program. And what they were able to do with that was to get a stop sale, stop distribution in place within 5 days. which I think is, something we really, I think it's a success story. And, sort of comparing where we are now to where we were before, so far this fiscal year, we've had 15 of these type of incidents reported to our program, where we've been able to coordinate the delivery of that information to the appropriate regulatory program. And what we try to do with that is it's not just providing, sort of this incident occurred. We try to facilitate the conversation back and forth. So what information is useful? Are we going to collaborate on the development of a public advisory? Is there, sort of additional information that would be useful? And we might even pull in, some folks like Pam and others to talk about plain language and, making sure that what we say on, for example, with Consumer and Hazardous Product Safety Director went out with a public advisory on bleach, that it was easily understood by the people that we want to receive it. So I didn't really answer the question around sort of the incident reporting process. If you go to the Healthy Canadians website, you will find sort of incident reporting, sort of by subject area. But the area that I'm really more comfortable to speak to is sort of how we coordinate the Poison Center information coming in and getting it to the appropriate program.
Hey, Richard, I think that's a really important point, is that connection amongst all of the poison centers and what they're getting calls about, what we're seeing is able to, as you said, get that response in place so much quicker than it used to be, and be able to see whether this is happening in just one area or if it's happening across the country, and take action in that way.
Absolutely.
Excellent. Thanks for that detail, Richard. Really interesting to learn what happens behind the scenes. We might see, an incident, we might see the outcome, but, all the things that happen in the system in between and the people that make that happen is really important to know about. This is strategically and intentionally done, and the fact that we're improving that in Canada is an exciting thing.
Yeah, I think what's really exciting is to encourage, if you see something, say something, thinking back to sort of a number of issues that came forward. I'm seeing this. I don't know if it's happening anywhere else, and to be quickly able to reach across the 5 poison centers to say, is it something or not? Is hugely valuable. The other thing that I think is really important is the engagement with other partners. So toxicology laboratories are saying they're seeing this. Our regulatory folks might be reporting the detection of a counterfeit product, or a group is aware of a product that there's no actual incident that's occurred, but this product labeling isn't understandable. Those are the types of things that really do need to be reported. And what we'll try to do is facilitate the conversations with the people that can, bring about action. And that's a lot of what Toxicovigilance Canada is all about, is bringing everyone together, share their information. How do we best inform action and, sort of prevention, treatment, and harm reduction? So facilitate and support as best we can. Sorry, I talk too much, but go ahead.
No, that's a good point. And going back to the question from the community, I mean, that's also important for consumers, for people, who are buying things online or in the stores. If they see something, say something, because the more eyes and the more information that we have, it doesn't just have to come from the professionals.
On that question, I'll wrap up our Q&A. I want to leave us with a positive comment in the chat, because it's always nice to hear the voices of our participants. And the comment is that the Saskatchewan Prevention Institute are excited about the upcoming Poison Prevention Week coming up March 21st, 2021. And as their organization focuses on children, they're running with the word power and taking on a superhero theme. So sounds like there's going to be some fun yet educational and informative information coming out of Saskatchewan Prevention Institute. So do be sure to follow Parachute, Injury Prevention Center, our poison centers, your provincial injury prevention partners to find out more about our upcoming Poison Prevention Week for this year. And on that, Pam, I will pass the mic back to you.
Thanks so much, Steph. Excellent timing. Thanks to all of our panelists today. It's a really challenging topic in some ways, but so it has such a potential to be addressed. I think there's the power of, using Kara's word, the power to actually influence change is there. And the more that we work together and have the basis of data and evidence and seeing what's going on and what is actually effective is really important. So thank you again to all of the participants who joined us today, and stay tuned for some new information on the other 2 webinars that are in this series, and we'll hope to welcome you back at that point. So thanks, Margaret, Richard, Wendy, Kathy, and Steph for fielding our questions, and wishing you everyone a great rest of the day.